Okay, hello everyone, hope you're all doing well. Welcome to the TRT Masterclass. I have been wanting to make this video for years. I haven't gotten around to it, and now I finally have the time to sit down and make this for you. As you're watching this on YouTube, you will have worked out that this is a free masterclass. I am very passionate about making this information as accessible and as understandable as possible. Big thank you to my friend Ali Gilbert, who's featured over here. Obviously, I am not Ali Gilbert, but thank you to her for having me in her studio. If you guys would like to check out her work, she has some fantastic programs for people who've just started TRT and who are wanting to get their fitness dialed in and sorted. I will throw up her logo here. You can check her out at Silverback Coaching. So what we're going to be going through today is the basics. And I think it's very important to revisit the basics periodically, because if we look back 5 years ago and even 10 years ago, what was considered best practice then may not be considered, and from 10 years ago definitely is not considered best practice now. A lot of the content that I make is talking about more high-level troubleshooting cases, but most people, actually I would argue everyone, at one point or another needs to learn and understand the basics. So I skip over the basics a lot. I have covered the basics very extensively in my TRT 101 ebook. I will put a link to that in the description. That's only $29. It contains a lot of the same information as this talk, but you can refer back to it. You can Control F to find the things you're looking for. Very cheap, very easy to navigate, and that's available for you if you need a guide to refer back to. Now, 80% of this masterclass is available in this YouTube video for free, and there is a 20% bonus module, which is more for practitioners and enthusiasts. It's more around fixing protocols, troubleshooting, a bit more of the advanced stuff that's more relevant to practitioners. That is available exclusively for members of my TRT Academy. It's $19 a month. You can join it via the description in the bio. Q&A is twice a week. You can post as much as you need to get the support that you need. It's affordable. It's available for everyone. But I can assure you that the vast majority of the information is available here. This is the main game. The content in the Academy is the DLC or the expansion pack. It is not the core component. We are going to be going through the majority of everything today. Big thank you to Ed and his team for putting together this video as well, so that it is as nice and easy to understand as possible. So without further ado, this may be a bit long, so please buckle up. This masterclass will contain everything you need to know about the basics of testosterone replacement therapy, which we will be referring to as TRT from here on out. What we're going to go through today is we're going to be introducing TRT, hypogonadism, and hypogonadism symptoms. Hypogonadism is the fancy medical term for low testosterone or low gonadal function, which the function of the gonads is to output sex hormones. So diagnosing hypogonadism and defining deficient versus optimal testosterone levels, the different modalities of TRT, the timeline of initiation, follow-ups, titrations, and symptom resolution, and the management and prevention of side effects. And in the advanced module in the TRT Academy, we're going to be going through fixing poor protocols, testing, diagnosing, and resolving common troubleshooting scenarios, as well as optimizing men under the age of 30. There's a little bit of nuance to that, but most of the content here will still apply to men of all ages, as young as 18 years old. So what is TRT? Great place to start. So testosterone replacement therapy is long-term interventional endocrinology to replace an intractable deficiency, meaning it can't be fixed, of testosterone production with an age-appropriate, healthy testosterone level through exogenous, meaning external, administration. This is to mimic natural production as closely as possible and to resolve the negative symptoms of hypogonadism, improve overall health and quality of life. This is what testosterone replacement therapy is. This is also referred to as testosterone optimization therapy. The two can be used interchangeably. TRT is highly invasive. We are going to get that off the bat. It is a serious intervention because once you start testosterone replacement therapy and your body senses that it now has optimal circulating testosterone levels, this will shut down your natural production. This is unfortunate. This is a byproduct of the treatment. If it wasn't for this, this would be a very quick video. So this is the main reason why testosterone replacement therapy needs to be taken very seriously, and we need to look at it as an intervention to only deploy if the symptoms and the low hormone levels cannot be resolved. And we're going to talk about that a bit more soon. TRT is administered typically via topical creams or frequent injections when the protocol is done right. If the protocol is done wrong, it is typically administered via infrequent injections, gels, or pellets. TRT is an ongoing medical intervention which requires long-term adherence, blood work, practitioner oversight, and a healthy diet and lifestyle. This, unfortunately, is news to a lot of people who've started treatment. If you do not tick each one of these boxes, you are not going to have your expectations met, and you may even end up in a worse situation than before you started due to side effects. I'm going to put a big emphasis on the need for expert, ongoing practitioner oversight. Facebook forums and groups are not your medical provider. They cannot provide you with the personalized guidance that you need. This is a uncomfortable wake-up call for a lot of people. And unfortunately, people follow the idea that you can do this for years and years and years and end up chasing their tail to the point that they end up having to see someone to fix the mistakes that they have unfortunately made. The healthy diet and lifestyle component is really important. And it's really important because, and this is a very fundamental aspect of a lot of what I try to teach people, is that if you are going to put optimal healthy testosterone levels into your body, you need to be an optimal healthy male to be able to tolerate that. Now, when you come from a hypogonadal state, there will be a healing process that you have to go through, from adhering to a healthy diet, lifestyle, and getting rid of a lot of your maladaptive coping mechanisms and vices for a period so that you can recover from this state. But on a long-term timeline, the majority of the side effects that people get on TRT, assuming the protocol is done right, come from poor diet and lifestyle, and it comes from ultimately living in a way that you would never be able to make the testosterone levels that you're injecting if you were physiologically able to do so. One question that comes up all the time is, should I take TRT? No one on the internet can answer this question for you. This question can only be answered by someone who has your full background and history and understands testosterone optimization therapy. So TRT should only be administered when optimal testosterone levels cannot be achieved naturally. Now, this may be due to age, chronic disease, or when natural hormone production still does not respond to proper diet and lifestyle as well as exercise interventions. There's this myth that is very pervasive, which is fortunately getting more attention over the last couple of years, which is that younger men are growing up doing everything right, kind of to the point that it's excessive. And despite this, they still have the testosterone levels of a geriatric, unhealthy man. There's a lot of theories as to why this is. I think that suboptimal health during puberty is a big factor, but what is the consensus is that this is due to endocrine disruption from the environment, as well as a shift towards more sedentary indoor living. It seems that we have a younger generation who are growing up that, despite even making all their best efforts, they are still not having optimal testosterone production. And there is a myth that was true maybe 20, 30 years ago, where if you were young enough, as long as you lived well, you would make healthy testosterone levels. This is not the case in 2024. So hypogonadism is diagnosed by a combination of symptoms and lab tests. It's not just one or the other, it's a combination of both. And a bit of a spoiler for later in the talk is that testosterone replacement therapy is optimized by a combination of symptoms and blood work, not just one or the other. It's not just about how you feel, and it's not just about how your labs work. It's a cross-section of the two. So what is hypogonadism? And this is a term that comes up all the time. So this is the technical term for, as I said before, low gonadal output of sex hormones, which in men is primarily testosterone and its metabolites. There's two types of hypogonadism in the literature. I would argue that there is this third type of hypogonadism, which I alluded to previously, which doesn't technically have a name yet. A couple of terms which I'll mention here. If they catch on, they're my terms. So the first one is primary hypogonadism, and this is a decline in testicular production due to age-related hormone decline, which is most common, or damage to the testicles. This can be to do with birth defects, testicular cancer, receiving chemotherapy to the testicles, or even a really severe acute testicular injury. My friend Jay Campbell has spoken a lot about his basketball injury, which led him down this road. A kick in the nuts as a kid won't do it, but a proper blow to the testicles that causes a hospitalization will often damage the testicles beyond repair. But typically, on average, when we're looking at primary hypogonadism, we're looking at age-related hormone decline. This is the male version of menopause, which is technically called andropause. Now, Secondary hypogonadism, which I think often gets misdiagnosed as the latter, is a suppression of pituitary signaling to the testicles, resulting in lowered testosterone production. This is characterized by reduced serum LH and FSH levels, luteinizing hormone being LH and follicle stimulating hormone being FSH. So there's a signal from a gland in the brain to the glands in your scrotum to tell them to do stuff. And when the body is sick and under a lot of stress, this signal goes down because the body goes, hey, we need to focus on survival, not reproduction. And our hierarchy of needs now dictates that we need to conserve energy and divert resources towards keeping you alive. The body and the brain are quite blind to this. So psychological stresses can cause these problems. Chronic dieting can cause these problems. Poor diet and lifestyle is typically what we see, especially obesity and insulin resistance. Now, the third type, which I mentioned, which I think secondary hypogonadism is often a misdiagnosis of and is very prevalent in younger men, is this new form of hypogonadism. I'm either calling it type 3 hypogonadism or generational hypogonadism. I think both those terms sound cool. If you can come up with a different one, please let me know. Maybe you can come up with something that sounds even cooler. But the concept itself is not cool, which is that we are seeing low testosterone levels despite positive diet and lifestyle practices and normal luteinizing hormone levels. So instead of the signal being suppressed or elevated because the body is either sick and under stress or the testicles are not responding, we're actually seeing the body going, no, hey, this is actually the correct amount of output that we need to be making, and the levels are extremely low. It's almost as if the body has regulated and morphed into thinking that it needs a lot less testosterone than it does. A lot of us will attribute this to what are called xenoestrogens, which are environmental synthetic estrogenic compounds, things like plastics, pollutions, and pesticides, which seem to be exerting a very strong biological feminizing effect on men, as well as in women, disrupting their progesterone production. This is causing a lot of problems in the younger generation. If you don't believe me, go look at a group of men aged 18 to 25 and compare that to what they looked like 30 years ago. It's pretty stark. This is more common, I've seen, in men born after about 1990. So how is hypogonadism diagnosed? So hypogonadism is diagnosed, as I said before, by a combination of symptoms and lab results. And it is integral to look at both. A hypogonadism symptom or a symptom list is very ambiguous, meaning it can be quite vague, and it can be caused by poor diet and lifestyle, as well as other conditions like hypothyroidism and metabolic syndrome, which is the consequence and umbrella term for insulin resistance, poor diet and lifestyle. Basically, your energy metabolism is not working properly because you're not eating the right food or treating your body the way it is supposed to be treated. It's very important that we have a look at this from an objective perspective, because if we give a list of low testosterone symptoms, which I'm going to discuss shortly, there are a lot of things that can cause this. Mood disorders, just generally poor circumstances, bad diet, bad lifestyle, hypothyroidism, liver disease, drinking too much alcohol on the weekend, eating too much KFC. There are so many things that can contribute to this. And in my experience, a lot of the time with clients, it can be a matter of helping them to understand that they're not getting away with the stuff that maybe they used to get away with when they were a teenager. And if they clean up their diet and lifestyle, they might actually feel the way they want to feel. However, there are plenty of men, as I said before, who are actually doing all of this or who do all of this as an intervention and their levels still don't recover. And it's very important, in my opinion, as well as the opinion of many of my colleagues, that we make the intervention with diet and lifestyle first, because it reduces the side effects of TRT when it is introduced, as well as it creates a scenario where we can potentially get the benefits of optimizing testosterone without the drawbacks of requiring lifelong hormone replacement therapy, especially from a young age. However, if the trigger needs to be pulled, it absolutely should be pulled. And I think that it's important that we look at both angles of this to say, let's avoid it where possible, but let's absolutely use it when necessary. And I think that it's important to look at both sides of that discussion. So it's also important to mention that androgen receptor function cannot be reliably measured. There are some new testings coming out that seem to be able to measure the response of the receptor via proxy, but at this stage, it is not a peer-reviewed and accepted method of determining androgen receptor availability. So hormones kind of fly around the body like balls on a pinball table, and you don't get any points until they hit the bumpers. So hormones don't do anything until they bind with the receptors. And it seems that some people have less sensitive androgen receptors or less total androgen receptors than others. And a big part of the treatment in terms of optimizing diet and lifestyle and other aspects of health, such as insulin sensitivity, liver, and thyroid function, is so that we can also optimize androgen receptor availability. It is crucial for the practitioners watching that you learn to test, interpret, and diagnose hypogonadism based off comprehensive lab tests to ascertain whether the low testosterone symptoms are directly caused by other identifiable factors in your patient's blood work. What this means is that low testosterone symptoms can be coming from other stuff. Selling a man testosterone is like selling a thirsty guy in the desert a glass of water. Everyone wants more testosterone. But if low testosterone is not the root cause of the underlying pathology, adding more testosterone in could make that underlying pathology worse, or it could create an intervention that the client or patient now has to adhere to for life, which wasn't necessary in the first place. So other factors that are important to look at is hypothyroidism, insufficiency of adrenal hormones such as DHEA. This is not to be confused with adrenal fatigue, which is not real. Insulin resistance, liver disease, sleep apnea, poor diet, chronic stress, chronic pain, hyperprolactinemia induced by a prolactinoma, and drug and alcohol use. These are all very important things to screen for and to discuss with your patients. So, what are the symptoms of low testosterone? I have a lot of jokes about this. One of my low testosterone symptoms is having TikTok installed on your phone. But in all seriousness, the low testosterone symptoms that we would typically see are low mood and energy levels, heightened sensitivity to stress and anxiety, insomnia at night, and then hypersomnia during the day. So can't sleep at night and then too fatigued during the day. This is a stress issue. Reduced results from training stimulus, significantly enhanced and delayed onset muscle soreness, heightened stress response during and after training, insulin resistance, poor body composition relative to diet, low libido, premature ejaculation, and erectile dysfunction, cognitive dysfunction, and brain fog. This is not a fun state to be in. It is affecting virtually all aspects of a man's life. The problem is that these symptoms can be caused by a lot of stuff. It's also very important to understand that these symptoms are very broad because testosterone impacts a lot of things in the body. So it is very important that when men are having these symptoms, that they get someone to come in and work out what's going on so that it can be properly fixed. There are a lot of supplements, there is a lot of bullshit that will be sold on the internet to try to treat these symptoms. And it's very important that men have someone objective who can come in, who they trust, who practices with ethics and integrity, who can say to you exactly what's going on and how to fix it effectively and efficiently. The next question is, what are the low testosterone numbers? What is hypogonadism? The problem for this, or one of the challenges, is that as someone who consults clients all over the world, everyone uses different units. So I'm going to focus on the two most common units today. There are others used all over the world. I'm going to focus on the main units used in the United States and the main units used in Australia and across Europe. For total testosterone, this is also used in the UK. And then for the free testosterone numbers, we're going to be going primarily with the gold standard for Australia, Europe, and the US. There are a couple of different units used out there a little bit, so you may have to convert the numbers, but this should help the majority of people. So it's important to recognize that the reference range has continued to track down for decades. We didn't start measuring serum hormone levels until the late 1900s, so this is not something that we've been able to even measure for a long time. And since we have started measuring it, they have had originally a gradual downturn and now a very significant, sharp, exponential south downturn over the recent decade. So when we're looking at the reference range, the number one thing that guys need to know when looking at their labs, and practitioners, if they don't know this, they shouldn't be practicing in the field, is that the reference range does not represent the physiological range. It is not adjusted for age. A woman's hormones on her blood are adjusted for where she is in her cycle and if she's pre or post-menopausal. A man's testosterone readings are not adjusted for anything. There is one measurement, whether you're 18 or whether you're 80. So it is very important that we also recognize that this is not a range that someone has determined is healthy. This is the average, which is called the mean, and standard deviations either side of the most recent men who have had their testosterone levels checked. These are typically men who have prostate symptoms. So we are typically looking at the 2024 elderly sick man's prostate symptom levels as opposed to the levels of what a healthy, athletic, thriving man should be. So it is very important that we take the reference range with a grain of salt and we understand what the numbers actually mean in and of themselves, not relative to where they sit on a range that actually doesn't create any tangible meaning. So one point that I'd like to make is the bottom of the reference range a decade ago is now considered the middle quartile. These ranges drop aggressively over the last few years. And I'm going to give some examples of the ranges that we typically look at. So it is currently November 2024. And as of writing this, the average total testosterone reference range that I see at the moment all over the world is about 7 to 25 nanomole per liter, which converts to about 200 to 720 nanograms per deciliter. When I first measured my testosterone levels, and you still find some labs in Eastern Europe as well as Mexico that have similar ranges to this, the reference range was 11 to 30 nanomole per liter. This, when you compare it to 7 to 25, is significantly higher. I have seen the top of the range go up to 52 in some niche labs. Now, when we're looking at free testosterone ranges, I have recently seen it as low as 150 to 550 picomole per liter, but it's typically 200 to 600 picomole per liter at the moment, which converts to about 57 picogram per mil to 173 picogram per mil. This is about the average. Only a few years ago, the average range across all of Australia was 300 to 800 picomole per liter. This is a big drop, and this is only within the last few years. There is literature which shows that the reference range previously went up on average to well over 1200 picomole per liter, and I wouldn't be surprised if it went significantly higher previously. These ranges are astronomically lower than they used to be, and they do not represent optimal physical health. They represent the health of the average gentleman who's having his testosterone levels checked, which is typically, under the circumstances, on average, of negative prostate symptoms. So from a clinical standpoint, and I'm going to highlight here and I'm going to get this out of the way, I am not a medical doctor. This is not medical advice, but I do co-own 2 clinics with teams of medical doctors who work on this. So as we go through this lecture, I am not posing as a doctor. I am not giving medical advice. Anyone in the comments who is harping on about this, I can already imagine people will be. I'm not going to read it and I'm not going to care. I am not a doctor. So from a clinical standpoint, we see hypogonadism symptoms begin to occur in some men with a free testosterone on multiple lab tests over a 6 to 12 month period of under 400 picomole per liter. We're talking about free testosterone, which in picogram per mil is about 115. And I see more severe symptoms occurring below 300 picomole per liter, which is about less than 86 picogram per mil. This is free testosterone, not total testosterone. This is well within the defined reference range. If you get below 200 picomole per liter or even 100 picomole per liter, which is when you really start to scrape the bottom of the barrel, symptoms will tend to be quite a bit more severe. One thing that we've just gone through and kind of skipped over is this distinction between total and free testosterone. Total testosterone is a measure of how much testosterone is being produced or being administered that is currently circulating via the blood in the body. This is a pretty damn accurate measurement because whether you're injecting testosterone, taking testosterone as cream, or producing it naturally in the scrotum, the testosterone gets produced in one place and travels around the body bound to a protein called sex hormone binding globulin, which is referred to as SHBG, as well as albumin, which are your body's 2 primary binding proteins. The vast majority of this is bound, and then the leftover, which is available to bind to the receptor, is called free testosterone. Now, I am going to flag here, and this may come as a surprise to some people, that this is not really accepted as fact. This is called the free hormone hypothesis. It is not completely clear what the role of bound testosterone is relative to receptor activation. My understanding and what the free hormone hypothesis supports is that testosterone can bind and unbind to SHBG, which essentially prolongs the half-life of it in the body. But it is not concluded that testosterone, which is bound, is biologically inert. But what is concluded, and what the vast majority of practitioners will attest to from seeing it in clinical practice, is that free testosterone is far more correlated with symptomology than total testosterone. I wouldn't go as far to say that total testosterone is redundant and meaningless, but free testosterone is absolutely far more significant for determining both negative hypogonadism symptoms as well as optimal response to treatment. How should TRT be administered? So TRT should be administered as frequently as possible to mimic natural production as closely as possible to prevent supraphysiological peaks or low troughs with deficient androgen levels. Previously, there were some arguments to suggest that higher SHBG benefited more from less frequent injections. This is bro science and is not true. The higher someone's SHBG is, the higher the total dose needs to be to optimize free testosterone, but it is not something that allows for a more advantageous treatment protocol for injecting less often. It is always more beneficial to inject more often or to apply testosterone more often for stability. Stability is one of the most important factors for optimizing a man's hormone system. Now, when we're looking at injecting, we have to find the sweet spot between what is something that is optimal and what is something that someone will do consistently for the rest of their life. Injections are not overly painful, but they are not completely comfortable. They are not as comfortable as swallowing a capsule. So we want to find a way that we can inject as often as possible, but not excessively, to allow us to have stable serum levels so that we can do this for a lifetime, and ideally with the least amount of pain and discomfort. We'll also be discussing topical cream. So testosterone cypionate and enanthate injections are our typical injections for testosterone. There are other forms of testosterone on the market, such as Sustanon, Nebido, also known as Reandron, which is injectable testosterone on decanoate. And testosterone propionate is not typically used for TRT, but I guess it could be, and I'm sure in some countries it is, but it is much, much, much rarer. This lecture will be focusing on cypionate and enanthate because I would say about 90% of people watching this will be using these forms or should be using these forms. Sustanon is very popular in the UK, and I would say that the same approach applies to Sustanon, but I would recommend that people inject a little bit more often with Sustanon due to the concentration of propionate and phenylpropionate. I don't recommend Reandron or Nebido. They simply do not work. So when we're looking at cypionate and enanthate, we say that we want you to inject it at a minimum of twice a week. There is also the option of using a highly bioavailable topical compounded cream, which can be applied to a shaved scrotum, ideally twice a day. When we look at injections, and I think there's a really good point to be made here, injections are not comfortable. Other than masochists, I don't think anyone really looks forward to their injections. Maybe at first as a bit of a novelty, but once that wears off, I don't think anyone really wants to inject anything unless you have to. So given that injections are still the gold standard for testosterone replacement therapy, it means that the other options simply are not as good. Otherwise, we would pick them over injections. Now, topical transscrotal cream, which I'm going to discuss next, I would argue is coming up to the point of being equally popular and equally effective to injections. But this is something that is slowly rolling out across the world as more people become aware of it. And I would argue that there are definitely situations where it is advantageous over injections, which I will be discussing more in the TRT Academy component of the masterclass. So cypionate and enanthate are extremely similar. I liken them to Coke and Pepsi. They're basically the same thing, but they're a little bit different. Cypionate has one extra molecule as part of its ester structure, leading to a slightly longer half-life. Now, given the half-life, depending on the research, is estimated to be anywhere from about 5 to 10 days. My understanding is that it's about a week. Some studies show it as low as even under 4 days. Some studies show it as long as 10 to 14 days. I think that the depth of the injection is a factor. Arguably, the carrier oil is also a factor as well. But when you average it out, when you look at the pharmacodynamics in the graphs, it's about a week, give or take. Now, given that cypionate has a fractionally longer half-life, I would argue that given that fact, it is slightly superior to enanthate if we're going to compare the two. It is splitting hairs. They are both completely interchangeable. There is nothing wrong with enanthate, and generally you'll have one or the other available. What we want to do is inject it more often than the half-life peaks and troughs. So what a half-life means is that if the half-life of a drug, let's say, is 10 days, it means it takes 10 days to eliminate 50% of the medication, bringing it down to a 50% concentration. Then it takes another 10 days to eliminate 50% of that, bringing it down to 25, another 10 days to 12.5, and so on and so forth. I think that a lot of the time, half-life is conflated with mean residence time, which leads to some confusion around these because this takes into account where the medication peaks and how the medication is distributed between the peak and the trough. But what we find to achieve stable levels and minimal fluctuations is that twice a week is the minimum that can be done. I would argue that it is much more advantageous to inject 3 times a week than twice a week, especially if your metabolic health is not optimal because you will be more sensitive to the peaks and troughs. What I like to say is you can get away with twice a week, and twice a week is okay, but 3 times a week I think is more advantageous. Guys can do every other day if you want to. It does mean the day of the week will change every fortnight, but it's not the end of the world. I just find it easier to say Monday, Wednesday, Friday. You've got multiple half-lives banked up over the weekend once you've been on treatment chronically, so it's not like you're going to dip by Sunday night. And this gives you a consistent, easy schedule to follow, easy to comply over time. You don't have to worry about it on the weekend. I think it works very well and it delivers a nice sweet spot. Injectable formulations typically come in 200 or 250 milligram per mil. I think anything less than that is just not worth using, but I guess if it's all you can get, with weaker concentrations being less ideal. In the US, the vast majority of TRT patients are using 200 milligram per mil. There's nothing wrong with this. But 250 milligram per mil is going to be better simply because you get more in a vial and you need to inject less of it. 200 milligram is not problematic. It is not bad, but if there's a choice between both, for obvious reasons, 250 milligram per mil is going to be best. To maintain consistent levels across a 7-day period and to avoid peaks and troughs, which are one of the main factors which induce side effects or lack of symptom resolution, we're looking at a minimum of twice a week. There's many men who benefit more from 3 times a week compared to twice a week. And as I said before, a big subset of these men are men with poor metabolic health. But there also seem to be guys that just metabolize the ester faster than others. I hypothesize that this is due to whichever liver enzymes are responsible for cleaving the ester in these men. It actually hasn't been identified which liver enzymes are metabolizing which ester, but I hypothesize that these men have upregulated enzymatic function, which is the primary factor for cleaving the ester. That's my theory, at least. So, as I said, every other day injections provide a similar outcome to 3 times a week, given the long half-life, but it is more of a tricky schedule to maintain. But if you prefer every other day, then by all means, there is nothing wrong with that. So, as I said previously, and I think that this is the best way to put it, is that the injection protocol should be as often as the client or patient will sustainably do over time. You want to inject as often as you can be bothered for as long as you can. I don't think anyone would prefer to inject than not have to take anything, but given the benefits of TRT, I think 3 little injections into the deltoid or the ventroglute with a tiny little insulin syringe 3 times a week is absolutely worthwhile for the benefits that you receive from TRT, especially with the ultra-stable serum concentrations. One thing that I will flag before we continue is that SHBG in groups, and I've even seen on some YouTube videos, is often touted as the primary variable for determining how often someone needs to inject. I think that this is fundamentally incorrect, and I think that this is a concept that has been parroted so many times that people actually haven't sat down to think to question this. I think that other than determining total testosterone dose and also being potentially a red flag for things like chronic dieting, excessive ketosis, as well as things like insulin resistance and hypothyroidism when it's high or low respectively. SHBG does not impact the half-life of the ester, which is the primary determining factor for injection frequency. It is only really responsible for determining the total dose needed to optimize free testosterone. It does not impact the rate in which the ester is cleaved. It only impacts the half-life of the testosterone once that ester has been cleaved, which I think relative to the former is inconsequential in injection frequency. You should inject as often as you can, regardless of your SHBG level. Very happy to debate anyone on the subject if they would like to come on the channel and do a discussion. I'm also going to flag here, daily injections are ideal because this gives you ultra-stable testosterone levels. It's kind of like if you were drinking coffee, not that you'd want to do this, but instead of having, a shot of espresso in the morning and a shot of espresso at noon, you'd just be sipping on coffee from dawn to dusk, assuming your goal was to remain caffeinated over the course of the period, which would not be good for sleep. But you get what I'm trying to say. If you can really frequently administer something with a very long half-life, you can keep your levels super, super stable. And I think that this is the most beneficial way to do TRT. However, when performing intramuscular injections, these are not sustainable long-term. I see some guys maybe do shallow IM injections with daily shots for a year, maybe 18 months, maybe 2 years, but I don't know anyone who's been doing it for more than 5. So if an individual tolerates a protocol well with a subcutaneous injection, this can also be an effective protocol. The literature shows that subcutaneous injections are very effective. In practice, however, a lot of men do receive welts and lumps and bumps and significantly lowered serum levels because they don't absorb it well through the subcutaneous tissue. This is simply the reality of what happens in practice. There can be as many studies showing that the sky is green and why the sky is green, but if you go outside and it's blue, it's most important that the sky is in fact blue. This is the reality of it. So my approach with this is that if you tolerate and react well to subcutaneous injections, and I also think that the carrier oil and how the testosterone is compounded is a big factor in this, and I imagine this is why practitioners who swear by subcutaneous injections likely also have a product that they consistently use for this. If this works for you, fantastic. Subcutaneous injections arguably reduce peaks and troughs even more, so you get super stable levels. But most importantly, you can now do an injection daily, sustainably, long-term for the rest of your life. You inject less often than most diabetics would using the same equipment. So this is absolutely sustainable and something that if it works for you, fantastic. However, I do find that about 50% of men do not react well to subcutaneous injections. If 100% of men reacted well to it, none of us would be injecting into the muscle purely from a comfort standpoint. There are also commercial preparations available on the market. I mentioned Sustanon previously. There's also Primotestin, which is particularly popular in Australia, as well as, I believe, Thailand. It's called Primotestin Depot or Testoviron Depot over there. These present challenges due to coming in a 1 ml ampule for Sustanon or a preloaded syringe for Primotestin. Ideally, if you're going to be using injectable testosterone, it needs to come in a multi-use vial, and you want to only draw from it with very small insulin syringes so that you don't compromise the seal of the stopper by consistently putting a hole punch through it. Now, you can draw and inject from a multi-use vial with an insulin syringe. It's not going to blunt the needle and cause trauma. I've seen there's a circulating image going around showing what happens to a needle. This is not actually the reality of what happens, and it is not a problem at all. So I strongly recommend that guys are using a 27 to 29 gauge half-inch insulin syringe, drawing and injecting into the lateral deltoid, or if you're particularly lean with good mobility, the ventroglute works great as well, but the deltoid is going to be the preference for the majority of people. You can inject into the quad if you want to. There are nerves and arteries in the quad, so you should probably aspirate it. I don't like the idea of hitting a nerve. I liken it to playing Minesweeper, and I strongly recommend that you go into the delts. It's easy, it's comfortable. Rest your arm on the table and put it into the shoulder in the muscle that you are targeting for your lateral raises. So ampules and preloaded syringes can work. If these are the only things that you have available, they can work, but you do need to find a way to transfer them into a sterile vial, which is not going to actually be completely sterile because you are not going to be doing it in a sterile environment. It is not recommended that you do this, but for the guys who have to make it work, this is unfortunately what they need to do. But you need to be aware that there are still going to be risks, theoretical risks associated with this, and you must do it with absolutely excellent hygiene practices. Do not store your testosterone in insulin syringes. I have done a video on the TRT and hormone optimization channel on this. It is very important you don't do that. The rubber stopper will break down. You will be injecting microplastics and all kinds of other chemicals into your body. Put it in a vial. They're cheap. They're available. Don't be lazy. So, cream. Topical cream applied to the scrotum for increased bioavailability is a fantastic way to optimize testosterone levels. My friend Dr. Keith Nichols has been a huge advocate of this for many years, and I would argue has brought this treatment into the spotlight. And also a shout out to Dr. Neil Rousier, who has some fantastic resources and training programs for practitioners. He's recently released a new book on this as well, and he has also been a big advocate for the benefits of cream, as well as Dr. Eric Serrano. The reason why we like cream is that you don't have to inject it and it works as well as injections. That's a very simple way to put it. There are further advantages to cream beyond just a comfort standpoint. And these are the areas that I am the most interested in. I do find that a lot of guys get injection fatigue after 5 to 10 years and the cream becomes very attractive. But I find that there is more benefit in application to the actual difference in outcomes that you receive from cream. So when you apply a testosterone cream and we apply it to a shaved scrotum, there's two reasons why it's applied to the scrotum. One is that you're not going to transfer it if you give someone a hug. You will only transfer it to other people if you rub your scrotum on them. Typically, people don't like that, so you'll probably have other problems if you're engaging in that behavior. The other advantage of applying it to the scrotum is that there's enhanced bioavailability. The skin on the scrotum is very thin, and it allows for significantly more testosterone to enter the blood, meaning less cream, less cost, a more efficient protocol. When we apply the testosterone cream to any part of the body, we get increased exposure to an enzyme called 5-alpha reductase. There are two enzymes that convert testosterone into its metabolites. One is 5-alpha reductase, converting to dihydrotestosterone, which is a very potent androgen. The other one is aromatase, which converts it to estrogen. Both of these hormones have a balancing effect on one another. There are situations where men will have a compromised function of the 5-alpha reductase enzyme, and these are in men which are typically the men who are most prone to side effects. These are men who are obese and insulin resistant, have chronic pain, or they have negative long-term side effects from the use of antidepressant drugs or anti-hair loss drugs such as finasteride and dutasteride. When this enzyme is downregulated, when we increase the amount of testosterone, we now have an unfavorable balance of DHT to testosterone to estrogen due to inflammation. The solution in this concept is not to block the aromatase enzyme, which will create more problems in the long term, but it's to optimize the way that the testosterone metabolizes into dihydrotestosterone, testosterone, and estrogen. I have found that men who would typically receive significant side effects from their treatment if they didn't correct their diet and lifestyle patterns very aggressively are able to have very side effect-free, very optimal outcomes from their treatment by utilizing the transscrotal cream application. Cream has a half-life of 24 hours. So while a once daily application can work, twice daily application is necessary for maintaining stable serum concentrations and producing the best results. I'm going to add in here that my friend who I mentioned before, Dr. Keith Nichols, has made a fantastic video explaining everything that you need to know about cream. He goes into much more detail than I do here. I'll pop a link up for it here. You can check that one out if you want to learn more about all the specifics of using testosterone cream. Cream should be applied to a dry, shaved scrotum, and bathing, swimming, or showering should be avoided for at least 3 to 4 hours after application. Transference can occur, so make sure that you wash your hands thoroughly after applying the cream, and if intimacy occurs, you need to wash it off before that takes place, as this will transfer, and women are very, very sensitive to increased testosterone surges. People will often ask, well, how long do I need to wait? I would say just have a shower anyway beforehand. It's polite. But in terms of how long you need to wait, I have seen some people say that anything after 2 hours is fine. I think that is a bit risky, and I think that that is pushing it. I would say 4 hours is a good indicator for what should be fine. But when in doubt, if you jump in the shower for 30 seconds to a minute beforehand, I'm sure your partner will appreciate it regardless. Cream comes in 4 compounded bases. There's the HRT base, the liposomal base, the atribis base, and the versa base. There are also just generic cream bases which don't fall into these categories. These are 4 popular topical cream applications for medications which have enhanced bioavailability via different means and processes. They are fascinating in terms of how they actually manufacture these, if you ever want to look into how these are created in compounding pharmacies. So when we look at the literature shows that HRT base is the most effective, followed by atribis and versa base are pretty similar, with liposomal last. However, I personally don't recommend either the atribis base or the versa base. The atribis base can burn the scrotum, and the versa base tends to leave a very chemically smelly, powdery residue, which I don't think is optimal at all. The liposomal cream is not bad. It's the least good out of 4 fantastic options, but that doesn't make it bad. If you have 4 fantastic flavors of ice cream and one's at the bottom, it's still fantastic. Liposomal cream works very, very well. It is the standard in Australia. As far as I'm aware, it's also the standard in the UK, and it is used interchangeably throughout Europe and the US. It absorbs very quickly, it doesn't leave a smell, it has fantastic bioavailability, and people typically respond very well to it. But there are always going to be a decent subset of non-responders to liposomal, Versa, and Atrivas-based cream. The HRT-based cream is superior to the other three creams in every way. It is more natural in its structure. It's primarily made of macadamia and olive oil, I believe. It absorbs very quickly. It absorbs quicker than liposomal. I liken it to it feels like a very good quality sunscreen. You're putting about half the amount of toothpaste you put on a toothbrush on your scrotum to apply this, and the HRT cream is vanishing. It is absorbed and it is gone in a matter of 10 to 15 seconds at the most. And we also find that the HRT base increases levels significantly beyond the other three, to the point that people can often even reduce their dose. And we find that more people on average respond to it positively. Some guys just don't absorb the cream very well from the other bases. So when the option is available, the HRT base is going to be the preference, and it should be the preference of any practitioner who is able to access it. But as I said, if the only option is liposomal, I do not think that is bad. I just think that the HRT cream is better. And it makes sense because the HRT cream was specifically made just for hormone replacement therapy, whereas the other creams are used for topical application of various medications. So there are other forms of testosterone administration that are objectively bad. There will always be exceptions to every rule. These are called outliers. They don't disprove rules, but there will always be outliers. So if you respond fantastically to pellets, if you respond fantastically to Androforte or Testogel, Nebido/Reandron, which is the long-acting testosterone injections, fantastic. Especially if you can get it affordably and easily and your treatment's working for you, that is fantastic. But for the majority of people, pellets are not going to work to provide optimal symptom resolution. Pellets are suitable for animals, not for humans. And the distribution over the usage period is not even. It's very difficult to titrate and infections may occur. There's also commercial preparations available of creams and gels. The Androforte 5% is probably the best of the worst. Testogel requires that you use a very large amount of smelly oil, goo actually, and essentially cover your body in it. You'd basically have to have a bath in this stuff for the average guy to get optimal testosterone levels, but some guys do great on it, but I don't recommend that anyone starts these treatments. A lot of the time, the levels and the symptoms can actually be worse than the hypogonadal state that was there in the first place. So I've mentioned Reandron/Nebido a couple of times. This is testosterone undecanoate. This is a injection that's promised to optimize testosterone levels with a shot every 3 to 4 months. So we're looking at 3 to 4 shots a year. That sounds fantastic. If it worked, we'd all do it. The problem with this medication is not only does it not actually last for that period, but on average, you end up with about 80 milligrams of injectable testosterone a week, which is about half of what the average guy needs to actually optimize his levels. It may be suitable for geriatric men, but for younger men wanting to optimize healthy physiological testosterone levels, this is likely going to put you into a similar range as mildly hypogonadal. Oral testosterone undecanoate does not effectively raise serum levels for long enough and would require 4 to 6 daily doses spaced evenly apart. There are new products entering the market, which I have not yet seen the data on. They do promise that these new oral forms, which are significantly higher dosed, will confer benefit. However, every promise made by every pharmaceutical manufacturer on new and improved testosterone delivery has not held up in reality. So I will be happy to change my stance on this when the information comes to light. But at this stage, there is not convincing data or clinical outcomes showing that oral testosterone is an effective way to optimize testosterone levels over a 24-hour period yet. Troches and nasal sprays also sound fantastic, but they have such a short half-life, a much shorter half-life than cream, and they don't provide stable symptom resolution. So how should testosterone be injected? Injectable testosterone is best injected via a 27 or a 29 gauge insulin syringe. So insulin syringes will typically go from 27, 29, 30, and 31 gauge insulin syringes. The higher the number, the smaller the needle gauge, meaning the higher the number, the narrower the width. You want to find the needle that's going to be the smallest needle that you can use, that's going to confer the least amount of discomfort, but will allow you to push the oil through the needle. Insulin syringes are made for water-based medications, not oil. Oil is thicker. However, when you're injecting a very small amount of testosterone oil, you don't need to use a large inch and a half needle with a 3 ml barrel, because one, we can't deliver a precision, precise dose, but two, you're going to basically stick a very large, uncomfortable needle into your body for no good reason. A 27 to 29 gauge half-inch insulin syringe, which are a bit longer than the smallest insulin syringes, will comfortably go into the deltoid for the vast majority of people. It's very important that you stick the needle all the way into the shoulder, so you almost create a dent in the shoulder and you push it right in. I call it burying the needle. Otherwise, you can find that the injection will seep out into the subcutaneous fat layer and it won't absorb as well for a decent subset of men. The ventricle and quadriceps are also an option, but they both carry the drawbacks that I mentioned before. And men with a higher level of body fat may require a needle a bit longer, but I wouldn't recommend using a needle longer than 16 millimeters to inject into the deltoid because you don't want to hit the bone. So I'm going to talk about dosing here. And there are different perspectives on dosing. My dosing recommendations are the same as they were in my TRT 101 ebook from a few years ago. Again, this is not personalized advice. Other people have different ways of doing it. That's cool. I've just found that from years of working clinic side with a lot of clients, this is what works well for the majority of guys. This is not a copy and paste prescription protocol. There are definitely individuals which do better with different starting protocols, but this is just a template for the majority. So injectable testosterone, in my experience, is best initiated at a dose of about 120 to 150 milligrams per week, split into 2 to 3 doses. I find that this level of testosterone administration will tend to bring the testosterone up to within the top quartile of the reference range or a quartile beyond the top of the range. This is not the optimal level for a lot of guys, but it's a great place to start to give the body time to adjust to a 3 to 4-fold increase in serum levels, and then you can titrate up from there gradually. I find that when guys shoot straight for the moon with their testosterone, they start on a very high dose. This can often cause a whiplash effect because they're going from 0 to 100 too quickly. It's not the end destination that was too high, it was that they got there too quickly. So this dose works well because it can split up into 0.2 3 times a week or 0.3 twice a week. It's an easy injection to split into twice or 3 times weekly dosing. And one of my recommendations I've made for a long time is the worse your health is, the more often you should start with your injections. Higher and lower SHBG, as well as age and other pre-existing medical conditions, other medications, mental health diagnoses, these are all a factor. They might initiate at a bit of a lower dose, such as 100 milligrams a week, or even higher at 175 to even up to 210 milligrams a week, depending on the level of SHBG, as well as even previous testosterone use. There are cases where higher amounts make sense to start with, but for the majority of people, that 120 to 150 mark is a good sweet spot to begin because you can always titrate up. I'm going to make a point here that I didn't plan to mention. Take your medication as prescribed. If you're not happy with how your doctor has prescribed the medication, find a better, more competent doctor who can prescribe you a proper protocol. Don't go online and make your own protocol based on what people in groups or YouTube videos like this one say. Videos and groups are to help you find a better provider who can take care of you personally. It's not to replace the role of a provider. So take your medication as prescribed. If you're not happy with how it's prescribed because you've learned and known better from videos like this, find a better provider. Don't try to do it yourself. So a 20% topical transscrotal cream, depending on the base, is best initiated at 1 to 2 0.25 mil clicks twice a day. There's various points in the TRT journey that I'd like to speak about. And in my TRT 101 ebook, I laid out a pretty similar journey. The most significant part of the TRT journey for most men when it comes to troubleshooting, when it comes to getting on forums, when it comes to contacting me and working with me in consultations, is the first about 6 to 12 weeks of treatment. This is where the body is going through an enormous amount of change. It's going through probably a similar amount of biological change that it went through during puberty, but in a much, much, much quicker pace. This is often subjectively uncomfortable, not necessarily bad, but there's a lot going on physiologically, and people can often become quite emotionally reactive to the sensations that they're feeling in their body. I like to encourage guys to frame it that you're supposed to feel something because you fixed a problem. Feeling things changing is good. It would be bad if actually nothing happened. A lot of the time during this period, men will find themselves overstimulated. They might have a bit of nipple sensitivity. They might have more energy. They might have difficult sleeping. That stuff is not ideal, but it is all stuff that is transient and will pass. So if the nipple sensitivity is becoming an issue, it's important that you maybe have an ultrasound to see if there's any gynecomastia pre-existing from before you started your treatment. Or if you are overweight and insulin resistant, you may need to look at increasing your injection frequency or using a cream or even adjusting your dose. But when it comes to the increased energy and stimulation, a lot of men who have an underlying psychological state of anxiety will say that it's making them more anxious. I think if you reframe it that you're more stimulated or you're more activated and you use that energy for something productive, like going for a walk, listening to a podcast, if you can't sleep, you previously were too fatigued and had no energy. So it can be a state of simply just pushing through the changing sensations in the body and framing them and using them in a productive way. So during the first 6 to 12 weeks, levels of injectable testosterone will climb in your blood every time you do an injection. So each time you do your shot, it's like 2 steps forward, 1 step back, 2 steps forward, 1 step back. And over about 8 to 10 weeks, these levels build up and become stable. And this is when we'll typically recommend that you go and see your provider for a follow-up so that you can see where those levels are at and how you're feeling. At this point, when you first have your treatment prescribed, you should know exactly when you're due to get bloods and come back to see your provider for a review. And it should be anywhere between the first 6 to 16 weeks, but 10 to 12 weeks is usually the most common. It's normal for this period to be a bit rocky. It's totally normal because there's a lot changing very quickly. And I encourage guys to not have emotional reactions to this and instead follow their provider's instructions. And if side effects persist at the 12-week point, that's a good time to have a chat with your provider about it. So your first review should occur once your serum levels have reached stability to see how you're traveling and to assure a proper pharmacodynamic response. Your levels should be on average where everyone else's are at this dose. If you're an outlier, if you're very sensitive or you're a very low responder, you may find that you need to either increase or decrease the dose. There are some men, as I've said in this lecture, 1 in 10 men will be hypo responders, and they will have a very, very low response and will often require 250 or 300 milligrams per week to get a decent response to treatment. And that's just to get their levels on the board. Other guys, even at 70 milligrams a week or even 100 milligrams a week, will achieve supraphysiological levels. So it is very important that you have this review to make sure that you're where you're supposed to be. This is the main purpose of this review, is to make sure that the levels are about where they should be and to be at a point that we can say, okay, we've reached a stable, steady point. Let's now give this treatment 4 to 6 months to settle in, and then we'll come back and see how you feel. One of the biggest points of confusion, protocols going haywire, and expectation management not being performed appropriately is that men will expect to have full symptom resolution and optimal testosterone function at this point in time. This is not a dumb thing to assume. With other medications or supplements, we reach peak effect when the medication reaches the peak in the serum. The part that people need to understand is that the majority of the benefits of high testosterone come with chronic exposure and saturation over time. It's not the acute effect. So if you feel 10% better at the 12-week point, that's something that should be celebrated. A lot of the time, men will have a honeymoon. They'll feel on top of the world for the first couple of months, and they'll kind of settle back into just being a little bit better than before they started. And they think that means they need to put the dose up or there's something wrong. No, this was just a sensitivity response, and now your body is normalizing to the treatment. It takes months and years to get the desired outcomes from TRT, and it's only when the optimal serum levels are supporting an optimal diet and lifestyle, which can often take months and years to correct these poor habits. So lab testing is very important. And I'm going to put a list up on the screen here of all the lab testing that I recommend that you get before starting TRT. Lab testing is not cheap in every country. In some countries, it's covered by insurance or public healthcare. In other countries, you'll need to get it privately. But skimping out on lab work from $100 or $200 to get a poor panel might mean that you get misdiagnosed. So it's very important that you have a comprehensive lab assessment before starting your hormone replacement therapy. Some providers may only check your androgen levels at your first review. This is not a red flag. So if you've had a comprehensive lab test before starting treatment, and then at the 8 to 12 week point, they're just checking your testosterone levels, this is okay because they will likely be planning to check your comprehensive labs at your next follow-up. Comprehensively, most things won't move outside of your testosterone levels for the first 8 to 12 weeks unless something is wrong. So it makes sense to save the patient some money that they are only looking at the testosterone levels at that first review and then reviewing everything comprehensively. Again, this list here again at about the 6-month point after starting treatment. This makes a lot of sense. It's important to have the exact blood test that your provider requests and prescribes at the intervals required. So if your provider says, I want you to get this lab test after this many weeks, it means get that lab test after that many weeks. It doesn't mean getting the few lab tests that sound similar or going through the list and picking off the ones that you think sound important and getting rid of the ones that you don't want to get, or going and seeing some GP to bulk bill them through the government's free healthcare system and you just get 20% of the labs and you blame the doctor, or you get them done after 6 months because you were too busy after 3 months and you couldn't be bothered. None of that crap should fly when you're optimizing your hormones. If you want to have optimal HRT outcomes, you need to follow instructions. It's important that you have a good provider, but it is equally important that you be a good patient. And in my experience, a lot of patients blame the provider for them being a poor patient and not following directions. So, what are the optimal TRT numbers? This is a very popular question. And I would say that my response to this is basically identical to what it was a few years ago in TRT 101. I find that most men do their best between the top quartile of the reference range to double the top of the reference range. Now, if the reference range keeps dropping, this might end up being triple the top of the range, but we'll see how that goes. This is where most men do their best. The vast majority of men need to have their free testosterone somewhere above the reference range to optimize their hormone levels, because the reference range does not represent optimal health. A red flag is a provider who will only bring your levels up to the top of the reference range but stay under that ceiling, even when your symptoms have not resolved. So, men of all ages and health statuses benefit from free testosterone levels, as I said, between about 500 picomole per liter all the way up to about 1500 picomole per liter. There's outliers that do better on either side, but this is a broad range for a broad range of men. If you are a 90-year-old man with diabetes, you most likely won't do well with the same optimized testosterone level as a 19-year-old professional athlete. This makes physiological sense. What is physiological for one man and supraphysiological for another man is going to depend on his overall health status and lifestyle. Physiological numbers are not determined by a number on paper. It is determined by the man's individual health and unique physiology. This is common sense, which is becoming more uncommon as the years go by. So, younger, healthier men often require levels greater than 1,000 picomole per liter, and I will get my editor to throw up the conversion for the US metrics here for that stat to achieve optimal symptom resolution. I find that closer to double the top of the reference range works better for younger men. There's a theory that I would support that exogenous testosterone is not as efficient as endogenous testosterone, meaning that when we're taking external testosterone, we need to take numbers a bit higher on paper to achieve the same effects as if it were natural. This makes sense to me that it wouldn't metabolize and work in the same fashion because it is entering the body via a completely different pathway, but this is a theory shared by myself and other colleagues. So an important note here with TRT dosing is that more is not always better. I would actually argue the majority of us are probably guilty of thinking this at some point in time, that more testosterone is always going to be better. If you take your testosterone levels too high for you, and that can be anywhere from the top of the range to double the top of the reference range and beyond, the first symptoms that pop up when you go past that sweet spot tend to be interrupted sleep, so more light sleep and less REM and deep sleep, increase in sweating, especially after eating, higher blood pressure, and agitation. Now, I believe we should be optimizing testosterone for the maximally tolerated dose rather than the minimal effective dose to improve benefits without receiving side effects or deleterious long-term outcomes. I think the minimal effective dose paradigm is important for pharmaceuticals, but when we're looking at bioidentical hormones, I think we want to go for optimizing the maximal tolerated dose without receiving side effects to receive the maximal benefits. Testosterone is good for you up to the point that it's not. And I think that it is important that we optimize testosterone levels because one thing that is very common, which is under discussed, is not that guys are taking too much TRT, it's that they are not taking enough. So I recommend if you are going to be titrating your protocol with your provider, and this is more information for providers now, that you are titrating by 5 to 10 milligrams per injection. Or if you're using a 200 milligram per mil solution, it would be 4 to 8 milligrams per injection. This is easy for men to draw out on the insulin syringe, and this would equate to anywhere in the ballpark of about 10 to 30 milligrams per week. Any more than this over a week, I find is too much too quickly. So if I was in a situation where I recommended that a client titrate their testosterone by 50 milligrams a week, I would recommend doing it by about 20 to 30 milligrams at first, giving it 8 to 12 weeks to settle in, check blood, see how they're feeling, and then potentially make the second part of that recommendation. I think getting from A to B is something that shouldn't be rushed. And I think any more than about 30 milligrams per week over the course of the week can be too much for a single titration all at once. I think you're better off making small adjustments and repeating every 8 to 12 weeks rather than potentially overshooting and needing to back down and creating further instability within the endocrine system. The endocrine system likes homeostasis. So it's also important to recognize that the body requires time to adjust to physiologically higher androgen levels. And I believe it's best to aim for levels, if we're going to look at a number on paper, again, for about anywhere from 500 to 1,000 picomole per liter to begin with, and then titrate up beyond that to find a symptom resolution for that individual. But again, there are always exceptions to the rule. So cream can also be titrated in single click intervals. And if it's not an even distribution, let's say a gentleman needs 3 or 5 or 7 clicks of cream per day, I think it makes more sense to put the extra click of cream in the morning because this would more align with the circadian rhythm. So I think it's important to look at a bit of a timeline here, and I'll throw the timeline up on the screen as well. So month 1, for some guys, will have a honeymoon period. Some guys will feel fantastic month 1, and they'll take 10 steps forward and then 9 steps back, and then they'll gradually start moving up from there. Other guys don't get a honeymoon period at all. So if you're 4 to 6 weeks into your treatment and go, I never got the honeymoon period, it's not that rare not to achieve this. At month 2 to 3, we should be looking at very mild symptom resolution at this stage. And as I said before, a lot of men think that they're going to have 80 to 100% of their symptoms resolved at this timeline. If you have 20%, you're lucky. At months 3 to 6, we'd expect mild to moderate symptom resolution. And from months 6 to 12, we would expect and hope for moderate symptom resolution with improvement in sexual function beginning. Sexual function seems to be the area that starts to improve last, and many men don't get the improvement in sexual function until about the 6-month mark, where it will continue to manifest over many months and years. So if you're 4 to 5 months into your treatment and your sexual function still hasn't improved, this is actually very common, this is very normal, and this is actually nothing to worry about. At years 2 to 3, we're looking at continued improvement in symptom resolution and early symptom relief. And from years 3 onwards, we're looking at symptom relief and long-term improvements and benefits. What many people expect at 3 months is what will take 3 years. There is mild symptom resolution occurring within the first year, but actual relief from the symptoms of hypogonadism is a multi-year process, not a multi-month process. I understand that people don't like hearing this, but it takes years to fix the damage that's taken years to accrue. So side effects. Side effects are an important aspect to discuss. Most people on YouTube who are watching videos about this are doing so because they're trying to resolve side effects. There is a lot of noise. There is a lot of incorrect information online regarding side effects. There are a lot of different stances. I have done my best to provide a very balanced and rational stance on this, particularly in the Beyond TRT ebook. Again, you can pick that up in the description, or there is a free YouTube link for that. I will also put that here. particularly around the side effects of estrogen. And I've also done a specific troubleshooting lecture, which you can check out here. So estrogenic side effects, and I'm going to put those in inverted commas, are caused by infrequent injection administration or high levels of systemic inflammation, causing the body to upregulate production of cortisol, adrenaline, prolactin, and estrogen due to the stress state. Estrogen is absolutely part of this inflammatory cascade. The most common cause of insulin resistance is obesity, followed by alcohol consumption, liver disease, and hypothyroidism. So all of these factors will impact your body's ability to utilize energy. And if the body is not making energy properly, it will become stressed. And in this stress state, if you combine this with high testosterone levels that you would never be able to normally achieve, your body is not going to metabolize it properly. This makes sense. So what we need to do, rather than trying to push the body into a different direction, is fix the upstream issue and modulate the TRT protocol to be able to better support the body while it is healing. But most importantly, people need to change their lifestyle habits, or they need to get proper comprehensive diagnostic testing to reveal what we actually need to do to resolve these issues. No man on a good TRT protocol should require aromatase inhibition. Bodybuilders and supraphysiological steroid users, this is a completely different story. None of this is healthy. But if we're going to be talking about optimizing testosterone in the context of hormone replacement therapy, there is no situation where using an aromatase inhibitor is going to be advantageous. There are underlying issues which need to be resolved. It's very important that there is a middle ground taken here, that we recognize that men are having side effects and problems, but that taking an aromatase inhibitor is not going to be the best solution for them. If anyone disagrees and would like to debate me on this, please contact Stephen, who is the owner of the TRT and Hormone Optimization channel, and I would love to discuss this live with you rather than bitch and moan in the comments. I'm not going to read the comments. So the other thing that guys can do here, as I alluded to before, in these situations is to use a transscrotal cream. And I think that swapping from injections to a HRT-based transscrotal cream, if insulin resistance is present, discussing something like metformin or daily tadalafil with your doctor can also be a good idea. But primarily changing the testosterone administration and frequency, as well as improving the diet and lifestyle habits, is going to be a big factor for this. And it is so important that you are all checking for subclinical hypothyroidism, because the thyroid is also a very important factor in regulating the production of aromatase and the expression of the androgen and estrogen receptors. You can read about this in my Beyond TRT ebook. So a second unrecognized cause of side effects is a reaction to the carrier oil. When we're looking at the carrier oil, this is the other ingredient in the testosterone injection. So when you're injecting testosterone, you're injecting a hormone that's bound to an ester with some preservatives in a carrier oil. This is the solution that you're drawing and injecting into the body. So there are different carrier oils used by different brands and different pharmacies, and it's not surprising that some people will have an immunogenic reaction to certain oils. So I prefer, where possible, to use MCT oil for two reasons. One, it's the least immunogenic, but two, it's also the least viscous oil, meaning it's the thinnest. It's the closest to water. So it means you can draw and inject it with a smaller syringe. It's more comfortable. It's a quicker process, and it's less likely you're going to have an immunogenic reaction to it. Not everyone can get MCT-based testosterone. So if you can't get MCT, I believe the next best options are going to be sesame and grapeseed oil. I prefer these over castor and cottonseed oil. Personally, I find that castor and cottonseed oil are very thick and they cause a lot of immunogenic reactions in people. This can be anything from systemic acne, site swelling, brain fog, lethargy, and hypertension. When it comes to side effects, I used to work at a mobile phone store when I was in university. And when people came in with troubleshooting issues, the first question that we would ask them is, have you turned it off and turned it back on? Back then it was, have you taken the battery out? This fixed a lot of problems. It didn't fix every problem, but it fixed a lot of problems. When it comes to the turning it off and turning it back on again version of this for TRT, that is increasing the injection frequency and changing the carrier oil. This doesn't solve every problem, but it solves a hell of a lot of them, and it's a great first place to start before getting more comprehensive troubleshooting reviews done to work out what is going on. It is very often a carrier oil and or frequency issue, and if you optimize both from the get-go, you can avoid this issue, which is why I will often recommend that people start with 3 times weekly injections of testosterone in MCT oil. Saves potential issues down the track. So there's some long-term considerations that I'd like people to make. And if you're just starting this or you've recently started this, it's important that you're thinking about this stuff now, even though it might kind of feel like it's a bit out of sight, out of mind. It's still really important that you're looking at this. So firstly, and I can't stress this enough as someone who has spent the last 5 years consulting with people who didn't do this to try to fix the mistakes, is have your treatment prescribed and monitored by an expert long term. So don't just get an expert to initiate it. You need an expert to monitor it long term. Hormone replacement therapy is like doing lifelong surgery on yourself. The money that you will save from going to an inexperienced budget provider, you will pay back 5 to 10 fold by fixing the issues that they cause. I can guarantee it because I've seen it play out every single day. The best way to ensure long-term success with your treatment is to go to an expert provider. I have a link here for my TRT FAQ that is free. You can download it. And on the last page, there is a full list of all my endorsed providers for TRT all over the world. Please check them out. The money that you save, as I said, from a budget provider, you will pay back, and you will also lose out on quality of life. Don't spend months and years suffering when you found out the solution, but would rather save $100 or $200 a year to get a cheaper option. You will get what you pay for. Surgeons all use the same knives, but a better skilled surgeon is going to deliver you a much better outcome than the cheapest one you found on Google. They've still got the same tools, they're still doing the same procedure, but the outcome will be very different. Hormone replacement therapy is exactly the same. You will get what you pay for. So every TRT problem can be resolved by an expert and competent practitioner. Every TRT problem can be prevented by an expert and competent practitioner. This is serious health interventions. Don't do it with someone who you don't have full trust and faith in. It is not worth doing. If you can't afford to do TRT right, don't do it. TRT requires blood reviews every 3 to 4 months in the early phase and every 6 months long term. Some people will require more frequent blood work if they have other comorbid medical conditions as well, but most people will get to a point where they can check their bloods every 6 months and they can basically do what I call a supervised set and forget, which is where you put it on the back burner, but you still do tweak it if needed over time. If you make significant changes to your lifestyle, if you put on or lose a significant amount of weight, don't be surprised if your protocol does need to change and become tweaked over time. This absolutely happens, and it's why we do need to continue to monitor every 6 months. Most problems and side effects on TRT come from a disconnect between the health of the patient and the healthy testosterone levels they are injecting. I liken this to putting a sports car engine into a Suzuki Swift. It doesn't work. The sports car engine doesn't turn your Suzuki Swift into a Ferrari. It will make it fall apart. So TRT must be used in combination with health practices and self-development to become the man who would be making those levels naturally if he could. This is a marathon, not a sprint. If you don't do the work, TRT will not work for you. A lot of guys spend months and years trying to biohack their way out of that one. It never, ever works. They're all dead ends. Just start doing the work now, and you will thank me later. I'm going to make some closing remarks here. So, firstly, don't overcomplicate it. I see guys who get into the weeds before they even learn the basics. So, focus on the important parts. Get your TRT protocol right. Eat well, sleep well, train well. Don't poison your body with drugs and alcohol. Get outside, go for a walk. Do these things consistently. And when you do feel anxious or concerned about your treatment, either breathe your way through it or speak to your provider. Don't derail your process by having an emotional response, going on Reddit, getting a bunch of advice from other blind people who don't know what they're doing either, and hoping it's going to work out. This is how things go haywire. Testosterone will only solve problems directly related to low testosterone. It gives you the foundation to solve the rest. TRT is not a therapist. TRT is not a gym program. TRT is not some kind of biohack where you can eat McDonald's every day and be healthy. TRT is simply the foundation that will solve the baseline biological and psychological states directly associated with low testosterone, but it is not motivation, it is not passion, it is not purpose in a pill. All the other problems which have occurred as a result of being hypogonadal for a long period of time, you need to put the work in to solve those problems now that you've got the foundation fixed. Cannot stress that enough. TRT will get you halfway down the road, but you've got to get yourself the rest down the road. We say meet the medicine halfway. As I said previously, I have a TRT FAQ. I'm going to put the link up again here. It has all the most frequently asked questions that I get about TRT. You can refer back to it. Totally free. And as I said, you've also got the list of all the best endorsed practitioners in the world, as well as my personal clinics featured at the back as well, which you can check out if you are in Australia, which is called Primal Zone, or in Europe called TRT Baltic. Finally, the last point I will make here is do not expect overnight results. The shorter your expectation timeline is, the greater your disappointment will be. Understand that this is like going through a metamorphosis. This is like a second puberty. You're going to have to learn and unlearn a bunch of things that you maybe aren't even prepared to look at. You are likely going to have to go through a bunch of habit changes, and that you're going to have to develop things like discipline and attention to detail and focus. And there are so many aspects that you will need to go through in an overall holistic healing journey that TRT is likely simply opening the door for you to do. Don't expect to become the Rock overnight. It is not going to happen. That is the conclusion of today's masterclass. I am going to be discussing some advanced strategies now for the TRT Academy. If you would like to join the TRT Academy and check out the exclusive content, you can join via the link in the description.